I'm just going to check my sound is working. Hello. That's great. So thank you very much for joining me today. It's a beautiful day here in Lancaster, and thank you very much for spending the time with me. Got people from all over the world as usual. It's fantastic. So this is my first of today's webinars, and we're talking about implant overdentures. So just the same as usual, if you have any questions at all during the whole webinar today, please put those into chat, and then what I'll do is right at the end I'll come back and have a good look at those and try and answer them in the best possible way. So let's dive straight into a case. So here we've got Lynn here. So Lynn presented to me in 2014. She was 54 at the time, and here she is. And before I tell you her concerns, I want to show you her mouth. So let's have a look inside there. And she's got these upper and lower teeth and not in great shape. We've got periodontal disease and we've got caries affecting those. She's also got horrible partial dentures that have just been added to over time that are not fitting well, really uncomfortable. So, but importantly, let's just go back to Lynn here and just look at what her dental concerns were and her wish list. So her concerns were she's got ill-fitting dentures. That's what she told me. Bad-fitting dentures. She's conscious about her smiling, and she covers her mouth up when she talks and laughs. She is socially inhibited both at work, and also she just got married quite recently, and so all of the wedding photos she just had no smile at all on them, and she's permanently putting adhesive on those dentures, and she lisps when she's talking. So, and now let's move on to her wish list. So she wanted to smile without crooked teeth, and she wanted to be able to go out more and socialize, and also talk with confidence and be really confident at work. She's got all these work colleagues and she shies away in the background, absolutely hates it. So anyway, went through all of the options for her, and this is what we decided to do. It's a joint process. We all discussed this together, so, and she wanted to have dentures, which were supported by implants. She wanted to be able to just like wake up in the morning and yawn, and the teeth not lift up and not move around when she's, socializing at all. She wanted confidence with them. So this is what we decided to do. Now, I've used Locators ever since they first came out back in like 2000, when I was working at Manchester at the dental school, and I really like them. I like them for various reasons. Number one, they are small, and so there's quite a lot of height above them in order for Rowan to put the teeth and metalwork and other stuff inside the denture, so it gives him more space. But also, importantly, when we're looking at this video as well, it allows the dentures to pivot and be supported by the soft tissues. It allows that movement there. So, and I really do think they're very good. Now, they have moved on to the RTX system, and there's quite a few others on the market that are all very similar and all operate in the same way, like Nova Lock, CM Lock, etc. They all work in just the same way and really, really good. So anyway, let's go back to Lynn now and have a look at her. So this was the treatment protocol that we went through. So we plan to do immediate dentures, upper and lower, complete dentures, and do the implant placement at the same time. Now, I used to place implants, but when I started the practice 13 years ago, I did it for a couple of years and then just thought, no, I'm going to leave it to an oral surgeon, leave it to the experts. So I have some really good surgeons that I work with that come to the practice and place the implants for me. So that's what they do, is place the implants. We then connect the implants to the immediate dentures, and I would do that 3 months after the implants have been placed. And then we would then wait a good 9 to 12 months after that and then make some definitive upper and lower dentures, which we'd then connect to the implants too. So that's the whole protocol here. So now the implant system that I use currently in the practice is Straumann. We previously used to use Astra, and then when this paper came out in 2015, which was a massive Swedish study looking at the best implants on the market, Straumann came out top. So as soon as that came out, I thought, let's just use the best, and we'll move from Astra to Straumann. So now when we're placing implants, we do scans, and then we get drilling guides made, and then we then place the implants are placed. And it's a surgeon that does that. It's a surgeon that does the scanning. But Rowan and I, that's my technician, we participate in the positioning of the implants. We make sure that we actually get surgical guides done beforehand, which are copies of the denture. And then when the implants are being placed, we make sure that the implants are positioned so that we can make dentures over the top that will work really well and also look good. In other words, if we have implants that are badly angled, it can really create a lot of problems aesthetically as well as functionally. It's very, very important. So when the implants are being placed, that we watch the surgeon, me and Rowan, watch the surgeon like a hawk, and we make sure that the implants. So, for instance, this is Lynn here, and we've got the abutments on already there, but this is prior to actually doing this. We made sure that the surgeon placed the implants so that they're nice and lingually positioned, giving Rowan plenty of space to think about the housing that's going to go on the top, and also the metal work to reinforce the denture, as well as the overall denture on the top. There's a lot of things to think about here. So now, if we now fast forward now 9 to 12 months after those implants have been placed, we're now ready to make the definitive dentures for Lynn here. And when I'm choosing the abutment heights, I just want them to be as low as absolutely possible. These are locator abutments. I want them to be really low. So, and we want them to be really no more than 2 millimeters above the crest of the gingiva, so that it gives Rowan plenty of space for the denture to go over the top. So I have a housing that fits into the denture, and then that denture fits over the top. So it's really important. Plenty of space, because there really isn't very much space under these sorts of things. That's what we find. So let's fast forward 9 months. So these are the immediate dentures here that Lynn's been wearing. These immediates were connected to the implants 3 months after the implants were placed. So we're now going to make definitive dentures. I like to make definitive dentures because we can improve the aesthetics, and secondly, we can make them with metal work in them to strengthen them, because people with implants can chew and bite and crunch really hard. So let's have a look now. We've got Lynn here, and we've got our locator abutment pickups in place with mushrooms on the implants there. So these are like little wine glasses, and then we do an impri-gum impression over that and pick those up. And these are what I'm looking for. I'm wanting to create beautifully extended impressions, just like I would do for a complete denture. So I'm not throwing out all those wonderful prosthodontic principles that I've learned over the years, so that the dentures are going to function really well. And should we lose any of those implants as well in the future, which does happen, implants fail, we can just keep those dentures going, and they're just like complete dentures, so they're future proof as well. But anyway, I digress. I want to talk about how to do the impression. So let's have a look at the lower here. So we get a special tray made, just the same design as I would do for a complete denture, using those Dr. Arbe 6 steps for producing that beautiful special tray. And then I put green stick onto the buccal shelves and also lingually all the way round. And I mold that in the mouth, doing the 5 steps that we've talked about. So it's E, ooh, licking the lip, push against the lower front teeth with the tongue and swallow. So that's molding these areas really beautifully to the shape of the mouth. And then what I do is I do the actual impression in Imprigum. So here we've got Lynn here, and Claire's got the retractors in, just pulling the lips away so I can see what I'm doing. So I'm going to take this to the mouth now. I'm just going to make sure that the sound isn't on, so I'm just going to talk it through. So here we go. I've got the tray loaded. I've squirted some of the Imprigum just around those mushrooms, those pickups. Here we go. I'll rotate the tray in place. Claire's got the retractors, just keeping that out of the way. Push it down onto the gum, moulding the cheeks there, and then I get Lynn to close up. Close. It's a closed mouth impression with that retromolar pad relaxed, and then ooh, lick the lip, push the tip of the tongue against that lower front strut. Good, powerful swallow. So all of this floor of the mouth and everything it's just border molding that impression beautifully. And then here we've got this lovely polished surface design. It's got everything, all of that detail, a beautiful peripheral roll all the way around that we're looking for. And this is the fitting surface of that denture, and we picked it up. So the next part of the process is to do our jaw registration stage. So this is how we do that. So just the same process, wax rims as a complete denture. And Lynn brought this lovely photo in of a dentate when she had her natural teeth, and we used that just to really try and copy that arrangement of teeth. So here we've got the wax try-in, which we then do a video of the patient. So Lynn will have a video with that in place, talking away and verifying it and making sure we're totally happy. But I do want to mention just one thing here about uppers. Upper unsplintered implants. I don't like using horseshoes for unsplintered implants. So if they're not linked together, so if they're all individual, like with Lynn, I like to do a full palate and get that wonderful support that we can get from the palate. It's just really, really important, because I've had my fingers burnt with implants in the past. So for instance, like this chap here, Paul, he had this horseshoe shapes upper, metal reinforced, and then I got a phone call from him when I was on holiday quite a few years ago. Finlay, my implant's come out. It's in my denture. So that unsplintered implant had come out. And what I find is that horseshoe shaped dentures just don't work as well for these unsplintered implants. And if you look in the ITI guidelines, the Straumann ITI group, they do recommend that if you've got unsplintered implants in the maxilla, we should do a full palate. So it's just something to think about. So I don't do them as a horseshoe at all. But when I'm doing my impressions for the upper, if I'm doing, say, a definitive impression for the upper, I will extend it just like a complete denture and do all of my border molding as usual. And and then I put my Imprigum adhesive on, take this to the mouth and do all of my border molding as I would do normally. So pulling the cheek, both sides, making it narrow under the base of the nose, waggle a jaw for the coronoid process, and then suck my finger, forgetting the modiolus, to just trim around the edge of the denture there. So here we've got Lynn's final dentures here. So these are the definitive dentures. These are metal reinforced. I'll show you the metal bits just in a minute and how we do that as well. So these are the dentures now. This was Lynn's occlusion. She's class 2, division 1 with a big overjet. That overjet's probably about 11 millimeters, but you can't tell actually when it's in the mouth. It really doesn't. It's not particularly obvious, but it's just we're putting the teeth back where they were naturally, and it's lovely. And this is how I fit them. This is really important here. I think this is a great detail. When I come to fit them, I don't put the attachments in. So Rowan doesn't process the attachments in for me. We leave a space for the attachments to be placed into the denture at a later date. So the dentures are fitted like this. So here's Lynn's denture at the fit appointment. If you look carefully inside that photograph there, you'll also see the metalwork in there. I'll talk about that in a minute, but we've got space there. So now when I come to fit the dentures, I don't attach the implants straight away. I don't attach the locator straight away. I let the dentures bed in first so that all of the soft tissues accommodate the saddles and all the other areas first, and then I attach the locators further on when the denture is comfortable. So here, this is what I do at the fit appointment. So we'll have Lynn in the chair. I put silicone on the fitting surface of the denture. I'll just go back, if you imagine that. So I'll try this in first like that and press it down hard. I'll ask Lynn to identify with it when it's in the mouth where it's sore, and she'll say, "Oh, a bit on that inside bit." I put silicone impression material, a light-bodied wash, it's a fit check, on the fitting surface. Take that to the mouth, press it down firmly, wait for it to set, take it out, and where it pushes through, so you can see I've marked it with a Sharpie here, where it's pushed through there, I mark it, peel off that silicone, and then adjust that with a tungsten carbide burr, and then take that back to the mouth and make sure it's totally comfortable. So I want to just check that. I want to make sure the occlusion's right, and then off Lynn goes. But interestingly, this is really interesting. This was Lynn at the fit appointment here. Once I've got everything really comfortable, and this is the complete lower denture there, and I'm just going to take it out. And you'll be able to hear suction on that. This is with no attachments on. So it's really good. So what we do is I wait and I get the patient back and I review them until that's totally comfortable. And then I attach the implants. And it usually takes 2 to 3 visits to get it comfortable. And then we can then attach the locators inside. And this is how I do the attachment process. So I pop these are the housings, and this is really important. This particular detail here that I'm going to say, I put a washer around that so that none of the acrylic, because these are the housings that are going to get picked up inside the denture. I want to put a washer that is a little PTFE washer. I don't want the acrylic going round underneath and locking onto the abutment, because if I don't do that, it will get stuck in the mouth. So the other thing that I do is I use a sand blaster. You can see this is the Rondoflex Cavo Rondoflex here. I sand blast those abutments, and it just makes the Oofy gel stick better, the actual acrylic composite that I use to pick them up. So that's, first of all, we do that. The other thing that's very, very important at this point is I double check that the denture itself, the fitting surface of the denture, is not rubbing on those housings, because I want the whole of that fitting surface of the denture just to fit passively over those abutments. I don't want it to scrape at all on those. So I use Occlude here. It's that powder spray that I love using for partials. Use loads of it for removable pros. It's brilliant. So where it rubs off there, I will adjust that with a tungsten carbide, or a diamond, actually a diamond crown prep burr. Just cut that away a little bit and then do it again until it's fitting beautifully passively. It's great. And then once it's passive, I'm now ready to put to cold cure the attachments in. So here we go. I use Oofy gel hard to do this. I make sure there's an undercut as well in this. I cut round with a round burr to make that Oofy gel stay in, just like we would do for a filling, like an amalgam, putting undercut in a tooth. Squirt it in. I don't put too much in. I don't like venting either, having holes put in the denture. It makes a mess of the polished surface on the outside. I prefer just doing it like this, not using too much. Take it to the mouth, and then I press that in place and just gently press it down so it's fully seated with my fingers on the premolars, the middle of the denture here and the middle of the denture there. And I don't get the patient to bite together, because sometimes they can bite in weird excursive positions and make this lower denture tip, and then it sets with it in that position. So it's really, really important. I put pressure on the premolars, get the patient to close up, but I've still got my fingers on the occlusal surface, so the patient may just touch my fingers, but they're not going to bite together. All of the pressure is coming from my fingers. I think that's really important. And then we take that out of the mouth, and then I change the attachment inside this in the denture to a really weak attachment. So I use one of the weaker ones here. I quite often use greys as well for other things, which have got no retention. They just offer support. So this is like 0.5 kilogram, 1 kilogram, and then 1.5 kilograms of grip. And this thing here is a locator core tool that you can order that with the locators, and that enables us to take them out of the denture and to refit them. It's quite a nice little neat tool to use whilst we're just changing those attachments. So you can see Lynn's dentures here. So I've taken out the lab insert, the black insert, and I've just put the blues in here. So that's what I like to use, is just blues, the lightest grip possible. And then we can then increase that further on down the line in a few years' time if need be. So here's Lynn, finished and job done. And, totally changed her life completely. The other thing as well is that we've got, and this is what I really love having, I love having spares. So we've got Lynn's first immediates here. So they're the immediates that we've relined, and they also connect to the implants. And then we've got Lynn's definitive metal-based ones there. So, and what I say to Lynn is like, make sure you take your spares with you wherever you go. You know, when you're on holiday, take them with you, because you never know if the others, you may have a problem with them. They may break or something happen. So that's a really important point. So, and then the other thing I want to just mention as well is this is Lynn's lower, and this is a video here that I show patients of before we proceed with implant retained lowers for 2 lowers, you know, the McGill type approach. So 2 lower implants, I always show them this. So we get good retention with these locators, but there's always a bit of rock. Watch this video now. This is very, very important. Look at how it can pivot. It's still really beautifully retentive, but the whole denture can pivot on those front implants. And this is it's a very, very important thing, because often patients will think that if they're getting implants, then the teeth will be as solid and as robust as natural teeth. But that just is not the case with 2 lower implants. It always pivots. So it will help keep them nice and stable and secure, but they will still rock. So now, the other thing is that I really hate things, the dentures that break. You know, this is a massive issue, is, you know, we can make dentures that are dead comfortable. So if we make a complete lower on 2 implants that is just plastic, so it's just acrylic, they can snap. So what we do is we reinforce these dentures with a cage, or we can sometimes use a plate if we've got less space. So a cage. Now look at the cross section of this. This is something that John Wibberley taught me years ago, was that the back edge here should have a T-shaped cross section here, which is like a girder. It's like an RSJ support, and it stops the whole thing from twisting. So it's not like just a piece of coat hanger wire in there. It's really, really solid. And then the denture encases that metalwork there. So that's one approach. Another one is, this is a lady that I recently saw, that Carol, she came over from Cork to see me, and she had 3 implants in the bottom there, but the denture we needed to make was thinner, and so we put a plate in. Can you see that there's a lingual plate on that reinforces the denture here? So and then the design of that lingual plate is really, really important. We have it's got struts that stick out and stick over the top of the implant attachments. So these metal struts just stick out over the top and then stop the implants being wanting to push through these housings, and it helps to strengthen that denture there too. So reinforcement is very, very important with implants. I can't stress enough how important it is, because when patients have got implants in place, the proprioception and the feedback going to the brain is just not the same as having periodontal ligament. And so patients can bite and chew on these implant supported dentures with massive force without actually knowing about it. So they are subject to, they have to be really, really strong. So our standard approach for uppers would be a plate, and this plate has also got mesh that comes out and spreads out over the occlusal surface, leaving me with an acrylic post dam, which allows me to reline that. But sometimes if a patient has implants like this lady here, this is Elaine. In Elaine, she had these old IMZ implants. She had 2 implants at the front there, and she came to see me with these 2 posts that stuck out there. And she's got natural dentition bashing on that denture there. So we put backings on that for her, because even when we made her one like this, she started to crack it along the edges there. So these are backings that come all the way up to the incisal edge. Really important, you know, super strong. Now, I just want to just share with you, I spent just over 6 years at Liverpool Dental School. I was a registrar there. That's where I did my specialist training in restorative dentistry. And as part of this specialist training, I spent 6 years on a implant review clinic. This was every Wednesday morning, and this was reviewing all of the patients that ever had implants placed at Liverpool Dental School. And it was a flipping nightmare. And I had to basically, I was there virtually on my own for that 6 years on a Wednesday morning. And I saw so many problems with implants, so many bars breaking, so many people that had dentures that they couldn't get out and they'd left in place for months and months and months, fractured screws. It was just everything you could think of that went wrong. So, and so there are, and there are massive issues with implants. and not easy to do, and you can just get yourself, I can get myself into so many problems with them, but doing this was a massive help to me. And this is where I started to make things much more simple. So if we had to say complicated beams and bars, I would take them apart and put locators in, and it just simplified that whole process and made everything much easier. So I just want to share with you now another case, though, again, and just share with you some more sort of complications that can occur with implants. So this patient came to see me, and let's have a look in her mouth. But in the upper, she's got a partial denture, cobalt chrome based upper, partial, and in the lower, a full lower on 2 implants. So she's got a really high smile line. Those chrome clasps on that partial were so visible, you know, when she was talking and smiling. She's got a full lower denture present there. But let's have a look in the upper arch first. So the left-hand picture shows the actual dental situation, and then on the right-hand side we've got the partial denture there. And it's a pretty old, ropey partial denture. She's lost a tooth here. It just needs to come much further back and be properly extended and get a better palatal support as well, and potentially think about something about these clasps here. The rest of the teeth were not in bad condition, actually. Let's have a look at the bottom there now. I'm going to just make sure you can't annotate. Someone's written a little red mark on that. That's it. Good. Here we go. So let's have a little look. I'll just go back. So let's take the denture out there. So actually, no, sorry. Good. Here we go. So let's have a look at the lower there. And so this is the lower. It's poor design, poor shape. It's not around the retromolar pads. It's overextended labially here. And we've also got problems with these locator attachments in there. So they're quite mashed up. But look at these implants at the bottom there. We've got an issue here with angulation. And these implants are certainly more than 30 degrees divergent. And even though the locator system says that we can cope with up to 40 degrees of divergence, it does create big wear problems. And it means the attachments inside the denture can get worn out very quickly. So that's number one. So we've got these divergents. So if we've got divergent implants, it's better for us to go from the pink, or the ones with the male insert in the middle, so blue and pink and clear, and move over to the ones without the inserts in the middle. That helps to make these longer lasting to start off with. But also the other thing that I do find with locators is, particularly sort of more elderly patients where their oral hygiene is not as good, food gets shoved into these areas too. So that it just gets packed in, like seeds and raspberry seeds and strawberry seeds, etc. And it just means that rather than the attachment looking really nice like this, all of this bit here just gets smashed up and mashed, and the whole thing, the denture, does not seat properly. So what I do with these circumstances then, so like this for this patient here, for Mary. So for Mary, what we did was I put in some clip here and here. So this is just like a temporary filling material, and we can always flick that out, and if we need to remove those abutments later, but that just stops the food getting shoved in, and it's really quite neat. And then just go from this to that. So this is like a temporary measure here. And then what we decided to do for this lady, Mary, was to make her a new upper chrome denture, a really lovely chrome, and a beautifully extended lower denture that's correctly extended, and it's going to be supported better by the saddles. So as part of this process, with these cases, I love using this Gothic arch tracing when I come to do my jaw registration stage, just like for a complete denture, and often with partials, I use this. It's fantastic for recording retruded contact position or centric relation. And you can see, so this is Mary's lower, and it just sits over the top of the abutments here. So this is on the definitive model. And then the upper arch, we've got this device here with a plate that just fits on the upper. And we take this to the mouth like that. And we do this at the right vertical dimension. So we've already used some wax rims to get the precise vertical. And then we then set this, and then we get the patient to move backwards and forwards and side to side. And then we can record the centric relation really accurately. It's fantastic. It's bang on. So, and that means we can then set all of the teeth up, and we've got the patient's just head on the bench like that. And then Rowan can just do that. But look at the actual denture there. I'll explore this a little bit more in a minute. So we've got this clasp that just comes around there. That's a dental D clasp, and it's a metal-based upper denture and a full lower. But before I look at the upper with you and explore that, this is the difference in shape. And this is with all of the webinars that I'm doing, I'm wanting to imprint a really good denture shape in your minds. So when you go back to work, you know what a good shape is. So, and it's just molded beautifully by the patient and fully extended at the retromolar pad. So this type of denture is so much better supported. And you can also see we've got that reinforcement of the metalwork inside too. So let's just flip them over. Totally different shapes. In other words, the new set is deriving much more support from the saddles, and as a consequence is placing less work is being placed on the implant attachments themselves. So that's the whole concept behind it. So that's the new lower. But let's have a look at the upper as well. I want you to have a look at this because I really loved this denture and the way it worked. It was beautiful. Again, it's using our Scandinavian design principles. So using that lovely, beautiful dental bar that is supported. It's just like a resin bonded bridge. It's all connected round here, using the pallet for support, and then embedded into that metalwork are dental D clasps here. And then when the teeth are attached, it's fully extended and beautifully supported, and it fits like a dream. It's beautiful. And we've got a lovely pin dam on our denture here just to seal it. And this is our dental D clasp that just comes round. So, and here we got the situation before we started and then after. And so, you can see how we're using the pallet to support the denture. It's hygienically designed. We've got these lovely dental D clasps that just come round here and here, and it's beautifully supported by the tuberosities. It stayed in place really nicely. So this is the end result that we did for Mary here, with the upper just stays in place beautifully with those clasps. And it's all metal based on the back, so should she lose any of those anterior teeth, we can add to the denture. She's got a full lower denture, and then the bite's absolutely bang on because we've used the Gothic arch tracing system, and we've got lovely even contact in centric relation there. So, and we've got a really happy patient. So if we look closely here, you can see the dental D clasp just there. So they don't look perfect, and but they're better in circumstances where patients have got a really high smile line and they've got an unrestored tooth that we don't want to drill or put a crown on or put an attachment on. It's just a much better way of, more conservative way of doing it. So it's great. So that's Mary. I want to now move to another lady here that's another interesting case here, which is Ellen. So Ellen was 93 when she came to see me. This was quite a number of years ago. She's almost 100 now. And so this is how she came. You can see that she's got that British standard denture look with the teeth are divorced from the ridge. They're just set back. They're not in the right place, those teeth. She's got upper and lower dentures. So they're too far down and in. So this is the looking at in her mouth there. So these are the dentures that she's got in. But let's take those out and look to see what's happening here. She's got a bar, and underneath this implant here, we've got a problem. So she's got no bone at all around this IMZ implant here. So that implant's been rejected. She had previously had an IMZ implant here where that Astra had since been replaced. She'd been seen in the hospital system here, and they'd actually replaced that, but now there was no funding to actually do the same here. So Ellen came to see me to get this rectified. So this Astra's sitting really nicely and secure. So we took that out, and then I made a new set of dentures on one locator. So, and there's some really good evidence, there's some good research to show that even one implant in the lower helps to improve a patient's quality of life. There's some good German studies where they've just put one in the midline and it's worked beautifully. And I find that they work really nicely here. So we didn't do another implant, we just kept that as it was, but we made one of these superbly extended lower dentures. And this was just after Rowan and I had been to Japan to learn from Dr. Abe about his suction denture technique, and I was experimenting with silicone impression materials here. I would do this in Imprigum now because I prefer it, Imprigum, and also with green stick. But it's quite a pretty looking impression there. But the whole shape is, we just copy that and it's fully extended, proper support from the buccal shelves all the way up the retromolar pad. So it's really well supported with that one implant right over the retromolar pad here. So optimal shape, just normal, as if it was a complete denture. And it completely changed Ellen's life, this. And she's had very, very little maintenance needed. I've seen her over the past 6 years since I treated her. I've had to replace the locator twice, attachment in that. She's getting on absolutely fine. She keeps it beautifully clean. So, and we actually used her daughter, who was in her 60s, we used her natural teeth as a guide for positioning the teeth for Ellen here. So that's why we gave her that look there, bit of wear, bit of movement. So the other issue with implants, which I really I feel very strongly about, is this. So this is Anne, and Anne's got a complete upper denture there, and we've used all of the different techniques. So we've carved the rim to get the teeth in just the right place. So this is using lip support and incisal plane, and also occlusal plane, which is parallel to the alar tragus. Now, when we trim all these sorts of things, we often find that at the back of the upper denture, when everything looks superb like it does for Anne, we've got very little space for stuff at the back. So imagine if Anne was going to have a fixed upper bridge on implants there, there'd be no room to actually put our implants or put our metalwork at the back here to actually give us enough strength to actually make a denture. This is really, really important. And also, imagine if she had a locator attachment here, just one single locator at the back there, there'd be still an issue with space. And we would have to drop the whole of the occlusal plane and make the patient look more toothy. And this is what we often see. You know, if you look at fixed upper all on 6 or all on 4 type arrangements, the patients often just look too toothy. There's too much tooth show, and it's purely because of a lack of inter-arch space. So this lady's what's called combination syndrome. So we've got the over eruption of these lower anterior teeth bashing into this maxilla here as well. But I do find that the tuberosities just get bigger and bigger over time as well. And they often, the level of the tuberosity drops below the occlusal plane of where the natural teeth would have been. It's a really, really important point. Space is always at a premium. So I want to now move on to a different type of case. This is a flipping hard case. So, and these are the types of cases that I get referred, and they are a nightmare to deal with, proper nightmare, with multiple different implant systems, etc. But you can see here we've got this lady's called Olive, and she's got Dentsply implants at the back here. These are ankylos implants at the back, and then these are old Friolite F2 push fits, and they fail. They just drop out over time. So this is how she came, and you can see that she's got a denture in place that is not attaching onto those implants at the top there with studs. So here she is. Olive's class 3. She's heavy on her teeth. She's a bruxist. This is the mouth situation when she turned up. So she's got studs on these back, on the ankylos implants here. These ankylos implants were in good condition. She'd had bone grafts, etc. But she'd also, in the past, she'd had F2 friolates and had lots of F2s that had all started to drop out. So that's why she'd had these implants placed to replace them further back, because she wanted to have a horseshoe shaped denture. This was like absolutely critical for her. She wanted a horseshoe denture. So let's have a look here. So that's from the front there. You can see she's worn this denture in, wearing it right down. Lots of repairs. This is often what we see with implants. They're so hard, everything's so solid, things just chip and break and wear. They are a nightmare. And then, if the implants themselves are all at different angles, this created a problem. And this was a number of years ago that I saw Olive, quite a few years ago. And so all of these upper implants are all divergent angles. So, and if I took out those studs and put locators on, they'd still be at the wrong angle. And so the components would still wear. So it's really, there were two basic options for Olive, apart from going in and putting more implants in a patient that's in her 80s. So, and which she didn't want to have. So we've got the options here. Number one, a full denture. That means we take all the studs off and I just do a lovely upper denture with good suction on, a full one, normal. Or if she wants to have a horseshoe shaped denture, we make a bar that fits onto the existing implants, not the friolets, just those back ones. And then we can then do a horseshoe. So she went away and thought about these two options and then decided to go for the horseshoe shaped denture. So that's what we did that's what we went ahead and did. And so in order to do a horseshoe denture, we need to put a bar in that makes all of the implants nice and parallel. And then we can make a bar sleeve denture that fits over the top. So I'll take you through that process now. So first of all, before I do anything, I wanted to know where we were going to put the teeth. So it's doing a wax jaw registration here and using that lovely dentated picture as a guide to help us position where the natural teeth should go. So this was our try-in here that we did, and she wanted it to look natural, so Rowan put a crown in at the front there and some different colours of teeth. So we tried this in the mouth there, and then we can then assess that, and then Olive can assess that looking in the mirror and looking in the video, make sure she's happy. And so with this trying one, so that's trying one, she hated it. She did not like the colour of those teeth and all the different, she felt that it just looked wrong. She wanted them all uniform. So we changed the shade and we went to C3 here. So that was our second try-in. So that's with C3 teeth. These are Enigma Life by Shotlander teeth. So we changed those to C3, the colour, and she was happy with that arrangement. So we made this. This was Mark 1 denture just for her to wear. And I just wanted to, because I knew she's very, very fussy. Even if we would talk with Olive now, if she was on with me here to chat with you, she'd tell you she's dead fussy about the aesthetics and every detail, very, very fussy. So here we are. So it's Mark 1, and this was just for her to wear, just as a temporary. We've got Moloplast B. This is a silicone material, and then she could then wear that. So, and then off she went. So that's where she was with the interim diagnostic denture. Let's call this the diagnostic denture there, Mark 1. So now, when she went away with that in, she said, I don't like the look of it, it's too dark. So we changed Mark 1 to Mark 2, and we gave it A3 teeth. So Mark 2's got A3 teeth. So this is still a diagnostic. We haven't gone ahead and done any bar or any expensive work. We just want to make sure we've got the right aesthetics, because she's fussy. She really wants it exactly right. So we made Mark 2. We actually made this in a horseshoe because she hated Mark 1 being a full palate. But this meant that this Mark 2 had really bad retention and stability. It just fell out all the time. It was not good. But anyway, she was very happy with that aesthetic arrangement. So we then can use this as a guide to start our bar fabrication. So, but it's so important to get the teeth in the right place first. So teeth in the right place before the bar's made. So it's prosthodontically driven bar fabrication. So we then go to a definitive impression with all of these abutments in place. So we put our fixtures. It's actually, these are the impression abutments. They go onto the fixtures themselves. I link those together with Luxabite and floss. So floss and Luxabite. I then do an impression in that open special tray with Imprigum, just like a denture, complete denture style impression. And that gives us a soft tissue model. So we've got this as an analog here. So this is an analog of the mouth there with soft tissue, definitive cast, and then a try-in. So that's an exact copy of the Mark II denture she's wearing. We then send that over to Spain, which is Createch. It's part of Straumann. So this is the company that we use for our bars, Createch. So that goes over there. They send us this file back, and we can then assess the space, because this is always the important thing with these sorts of things. We want to know we've got enough space for a bar and enough strength in the bar, and then the denture fitting over the top with the sleeve in. It's got to be strong enough. And so that was fine. So what we did then was they sent us the bar back. So I put in these universal abutments that Createch sends. They send all this stuff with all the right screws. And then this was the parallel bar that I fitted on that there. And it's got 4 locator attachments in. It's a bit overkill. You don't really need 4 locators on it. And we can now use much smaller attachments. But this is what I was using at the time. So this is a milled parallel bar. So that fits into the mouth. And then over the top of that is machined and milled a sleeve that fits that bar perfectly. That sleeve fits inside the denture itself, like this here. So that sleeve fits over the bar. And in fact, we get 2 sleeves made at the same time, because we make 2 upper overdentures for the patient in these circumstances, because they break, they wear them out. So it's nice for them to have 2. So once we've got the sleeve and we know everything's all fitting perfectly, Rowan sets the teeth up. So he opaques the sleeve that fits inside the denture. So that's the pink stuff. So that's the sleeve that is going inside the denture. The denture teeth are fitted on top. And then we go to a try-in of the definitive dentures. So we could call these the Mark III dentures. Now at this point, I want to make sure Olive is totally happy with the aesthetics. So she has a good look at them here and make sure she's totally happy with it. And we want to make sure and it's really, really important that she's totally happy before we finish, because it's so expensive having to start again at this particular point. And she was really happy with that. So Rowan beautifully finishes everything, flasks and packs, does the gingival colouring, makes it look really superb, and then finishes the denture. So, and we've got 2 of these identical, but this shows it from the side here. And this is why in Olive's case, there's no way I could actually put a fixed bridge in the top there. Can you see the massive, to actually support the lip properly, we've got to have a proper flange on that there. And there's no way we could do something that was fixed and that is cleansable. Very, very important. So she's edge to edge there. That's it. These are the 2 sleeves. And that's what she finished up with there. So those 2 definitive dentures at the bottom there, they're the ones that she wears. So if you imagine this one will be worn on a Monday, that's a Tuesday. swapping Wednesday, Thursday, Friday, Saturday. So she's actually alternating those, so they wear at the same rate. So when one catastrophically breaks, she's got another one that she's comfortable and can wear really well. And then it means that Rowan is not under pressure, my technician, to get it repaired and refurbished, because they flipping break these and wear them. That's it in place here with it finished there. And, you know, she can get under that bar and get it clean nicely. And she was really happy with that there. And then if we now fast forward 4 years later, she came in like this. Flipping heck. That upper left front ankylos has failed. And look what's happened. That's come out. And because that implant here, that support implant, has lost its integration, it's loaded this bar, and she's heavy on her teeth. She snapped it in half. This £30,000 worth of treatment down the pan. And this is the issue with implants. And this is, I want to warn you younger dentists that are going to go ahead and do and work with implants and think implants are savior and are brilliant. They're not. When they go wrong, it's massively expensive, and we've got to be very, very careful with what we're doing. So anyway, she comes in like this, and so I just relined that front section just for now. And then what we did was we made her a complete upper denture, metal based, and then put healing abutments on all of the cover screws on all of the rest of the implants. So effectively she's got a complete denture now, and that's her finished and done. And it's just future proof. It's so much better, and I feel so much more comfortable with her having this. Now she's got slightly shortened dental arch, and so the occlusion, we've actually engineered it so she's biting on there, that the back of the denture, as far back on the denture as possible, to help to keep it as stable as possible when she bites together. And it's got fantastic suction, this thing. This is me when I came to fit it. I can hardly pull that thing out. I'm really gripping at it. It's just amazing. It's fantastic. It's really great retention on that. And if we'd have done that right at the beginning, we would have saved so much hassle and heartache with the implant failing. So, but this is how she is now and working, and she's managing fine. She's not totally happy, I have to say. You know, she would love it to be more fixed in place. It's still got fantastic suction, but she still really hankers after something that is as solid as her natural teeth. So anyway, I want to thank you very much for spending this hour with me just now. And so what I'm going to do now is, as usual, I'm going to have a good look at the questions and see what I can do in terms of answering them. I bet there's some difficult questions today, because there always is with implants. Everyone's got their own opinion about these sorts of things massively. So now I'm going to be doing this lecture again. I'm going to do it live tonight at 8. If you want to join me then, that's wonderful. And then next Tuesday, I'm going to do another lockdown webinar. And if you have questions for any of the stuff that I've been doing over the past few weeks, just send that in, and I'll do my best to answer it at that particular Q&A session. So I'm now going to stop sharing my screen, and I'm going to have a look at the chat box here. That's great. Hi, Tom. Thank you. That's lovely to see you, Tom. Booth, Miriam. That's brilliant. So Brett from Australia. Hi, Brett. He sent me a lovely email from Adelaide. Elizabeth from Adelaide. Anna from Poland. Rebar from Bristol. from Australia. That's fantastic. Thank you so much. In Vietnam, it's great. Let's have a look here. So David Attrell, wonderful. That's great. So that's lovely. That's superb. See Mark Bishop, it's great to have you here, and Kiri from Bergen, and everyone, thank you. Gran, let's have a look now. Let's get onto these questions. Got someone from Tasmania, it's lovely. That's brilliant. So here we go. I've got the first question here. So let's have a look. So Miriam, one. Hi Finley, how do you decide for implant supported dentures versus conventional full dentures for this case? So that would be the first case. So that was Lynn. Now seriously, this is what I would prefer to do is I want to give people the most simple restoration possible that is going to satisfy their needs. And in general, I say to the patient, look, I would prefer to give you normal conventional dentures. If you find that they are not what you're wanting in terms of your quality of life, then we can always upgrade to an implant overdenture. However, this is dead important, is that I've done this is, and that's my normal approach, but all of my patients that I've treated over the past 13 years at the practice using that approach, where we've not done implants and we've just done conventional full dentures, none of them have had implants placed yet. No one's come back to me and said, I want to have implants done. I want to go ahead with that. So with using all of the techniques that I've shown you. However, it will happen. I will have a patient that will come back and say, yes, I need it. But it's a really difficult one, I find, because, and this is a discussion that I have regularly with people, is that the McGill consensus says that the best thing for a edentulous patient is to have 2 implants in the canine region, intraforaminal region there, and that gives the patient the best quality of life. So in some ways, I think there's a balance to be had here. So I will encourage people to have implants and say, look, I think your quality of life will be better, but we can always try it later should the complete denture not work. And the other really important thing is, before implants are done, the implants must be placed in the right place, and we need to have a really good denture to do that with first. So a really good denture as a guide for positioning the implants is what we need first. So we've not lost anything if we do complete dentures to start off with. Not even money. We haven't lost anything. Upan Patel, locators on implants in the maxilla. Have you noticed a higher incidence of implant failure in the maxilla when locators are used? Yes. The implants fail in the maxilla. The bone is soft. It is not very good. It's very poor quality compared to the implants in this area here are just brilliant. And with modern implants, I hardly see them failing at all. I can't remember of a modern implant failing here, but in the maxilla, it's a different matter altogether. How often do you replace the plastic inserts for locators? Not very often if we make the dentures really well. So if they're well extended, but it just depends on the angulation of the implants up. And so if the implants are really nice and parallel, then the wear on the locators is much less. I've not got very much, in fact, I've got no experience of using the angled correction systems for like Novalock or the CM lock, where we can actually angle it first and then do that. I used to use some Bredent ones, which were angled abutments too. And then I'm just going to put my speaker view on because that's lovely there. And so I just put off because someone just came up there. So yeah, I've used these angled abutments for correcting angles, but they're massive and they take up loads of space. horrible. Have you needed to replace the metal locator abutment that screws into the? Yes, they have to. Yes, quite. If the implants are angled, the locator abutment does need to be changed quite often. I don't mean quite often, but every so often, maybe every year, 3 years, something like that. It just depends. What are my thoughts? Michael Vida, what are your thoughts on mini implants? Bad. I would not put the fine if you're in a system where when patients pay money, and this is the thing, and this is what I really, it was like when I'd done my specialist training, I came out of the hospital system and I was so used to just doing stuff. And then if it didn't work, and we try our best, if it didn't work, there was no financial consequence. As soon as I come into practice, though, there is a massive financial consequence of getting things wrong. So mini implants, we could put them in, but when they fail, you've got a cross patient. Even if you've consented them to the nth degree, I'm not cool at all about them. But I'm sure they have their place as a temporary measure if you're in hospital or whatever, but not for me. The patient, so Car Yan Yim. The patient is on a complete denture while waiting for the implant to osseointegrate. Yes, that's right. Yeah. How long do you send implant retained dentures away for before attaching to locators? So 3 months. It's 3 months for the implant to integrate, and then we can attach it. Richard Gray, I find in the locator abutments wear over time. Do you replace them at the same time if constructing a new denture? What is the best height for the implant, for the abutments above the gingival tissue? So 2 millimeters, Richard, above the, so as low as possible. And yeah, I do sometimes change them. So Tony Lung, can you comment on your preferences of lower implant locations for implant overdentures, laterals, canines, or premolars? I think canines are really great. If we can get them in the canine regions, they just seem to work nicely. Premolars, sometimes it's just not possible because of the mental foramen and the ID nerve. And any further forward, it's more tipping. So canines are great, Tony. Dennis Osmanov, pivoting, is that an issue with sticky food? Yes. Until the patient gets used to it. But it's all, Dennis, this is really important. It's all about warning the patient before we actually do the treatment. So that's why I show them that pivoting denture on locators before we actually do it and say, look, when you have this made, it's going to be like that. It's going to want to rock. So if you chew sticky food, the back bit will lift, and you'll have to learn, just like a prosthesis, just like a prosthetic hand here, it will operate totally differently than a natural hand. It's just like a denture. So Jay, is the metal cage cast in the chrome? It is, it's cast in chrome, yes. So Miriam Oppenheimer, how do you make sure the denture is not hanging on the implants without sufficient support of soft tissue, especially with tume? I don't understand that. Miriam, if you want to rewrite that question, Miriam, I just don't quite understand the last bit on it there, but I'll come back to it. So hi Laura Tassol, please could you remind me why you do not green stick the labial margin of the lower special tray? So yeah, I don't want to have it too thick, the flange there, because there's very little resorption at the crest, at the edge of it. So just underneath here, for instance, underneath the base of the nose here, there is this basal bone doesn't resorb. So we want the flange. If we want to give the patient beautiful lip support, then that's the reason why. And look, John Besford, hiya John, I didn't know you were watching. It usually encroaches on the activity of the mentalis. That's why. It's just to give the patient beautiful lip support here. Really important. If you have a look at our papers, Laura, in the from the website finlaysons.co.uk speaking, just scroll down that page, right down. The 3 British Dental Journal papers that we wrote, me and John Besford, and it talks about this lip support and why the flange has to be really thin at the front. So Stuart Crook, hey Finn, what is your preferred locator system? Well, I've used the normal locator system, Stuart, since the inception, and you know what? I don't do many implants at all, so I've only just got a very limited experience of the new RTX system, which is the newer version of the locator system. So it's really watched this space, Stuart, for me. I do think it will still work fine. So RTX, but I think Novalock's fine. You know, I don't have an issue with any of them. It's just learning how to use them really effectively. Sorry, I know it's not a great answer for your question. Adeline, right. Does the problem with pivoting in unconnected lower implant supported full lower mean patient must not bite into stuff with front teeth? Not necessarily, no. It's just training how to control the prosthesis with the lips and tongue when they're biting. But certainly I don't think biting is an issue there. It's sticky food at the back, you know, just wanting to make it come up. Or even just playing with it with the tongue. Rhoda Jobling, hey Finley, what are your thoughts on flexible clasps and flexible dentures? Well, flexible clasps are fine, Rhoda. Flexible dentures are really bad because they twist and we get inflammation, we get overgrowth of tissues, we get periodontal problems. Flexible dentures are only any good for temporary measures, really. That's my personal opinion. I know I'm being very dogmatic about it, but that's what I would feel. So Kiri from Norway, hi Kiri, what are the indications for using a dental D clasp rather than an I clasp or others? Kiri, aesthetics. If a patient's got a really high smile line and shows a lot of the gum, then dental D looks better because it's not metal. So if the patient's got a hidden smile, then I would use metal, prefer it. What material did you use for the dental D clasp? But it's called dental D material, Leela. So Miriam Oppenheimer's asked about how long the dental Ds last for. So they last for a long time because but it's all due to, Miriam, you've asked a question about implants and using them as support and things, and if you're not extending the denture properly, then it'll wear that attachment more. It's just the same with partials and dental Ds. So if we've got a denture that's not well supported, so like with the Mary that I showed you there, it was all supported beautifully by that dental bar and maximally. So it stresses the dental D much less. So John Besford's asked a really good question. Your upper dental bars, especially over composite rest seats, are quite thick. Does this create speech problems with sibilants? And can they be anticipated by pattern resin rehearsal, which you frequently use before the metal is made? Yes, that's absolutely right. So rehearsal, but it's also warning the patient right at the beginning that it will take some time and practice to get used to making S sounds and sibilants there. So rehearsal with the metal, with the mock-up pattern resin, and then making sure that the patient is aware of that. But they, seriously, to be honest, they just do not have long-term problems. So we've got Ned Flanders from the Simpsons here. Where do you prefer the implants to be placed? In a 2 locator full low? In the canines, Ned? So someone's asked a private question about covering retromolar pads in lower dentures, and patients don't like it. So now I've been using this technique for quite a number of years now. So I've made a good few hundred dentures where we extend it up the retromolar pad. I've only had one patient that's not been able to tolerate it, and that was Lynn, who is one of my most difficult cases. You can actually see her case presented in, I put it on YouTube recently. It's my most difficult denture case. So she's the only one. But it's very important, the retromolar pad area is, it's got to be just right. It's not got to be too big or too small. So it's just got to fit perfectly over the retromolar pad and not be overextended. And also, we've got to take into account the Samaya sinew string that comes across the side here too. So all of those areas have got to be relieved. That's really important. And also, the other thing that can happen is that the heels can contact at the back too. So when we've got the dentures, I'll just get this into occlusion there. So can you see that the heels can sometimes touch there, or the soft tissue can get trapped between? So it's important to adjust that area, and it's better to adjust the upper denture to create a bit more space for that too. So there, it's just looking for those problems. It's a good question. So Stuart's asked about your case with the combination syndrome. Can you go back over how you dealt with the lack of space? So yes, I can, Stuart. I'll find that. I'll just do a screen share. And I just want to make the point I'm making about this, Stuart, is it was in this, it's with Anne, her case is just a conventional denture, so the space issue is not a massive deal. But it would be if she needed some implants. It's really important, and no one talks about it. I don't know why, because it's so important. Right, this was Anne here. So she's got the full upper denture in place, and this is her denture in. This is her model. The interesting thing about Anne, this patient, was she was an artist, and she, if we go back to her there, her previous denture, the one that we replaced, she'd actually set her teeth up herself in the past, and she wanted porcelain teeth, and she wanted porcelain teeth in the maxilla as well, for her denture there, because she wanted to have the sound when she was biting, the little, like porcelain, the chink sound of porcelain onto natural teeth. She didn't want it like a dull sensation or sound like acrylic does. So I said to her, yeah, we'll do them with ceramic. But when we actually came to set the teeth up here and with the right aesthetics, we couldn't use porcelain teeth at the back there, because porcelain teeth don't bond to the acrylic chemically. They have to have little holes in that retain it inside the denture. So we gave her ceramic teeth at the front, so upper 3 to 3, because there was space to do that. But at the back, we had to use our standard acrylic teeth, and then Rowan can cut them right down so they fit right onto the ridge, and then they get processed into the denture just like that. So that's why this was an interesting case for me. But as a separate point, Stuart, what I'm trying to say is just think about it. If you are going to have implants going in here at the back there, and then you've got a locator abutment on the top of that, and then we've got metalwork inside the denture, we are just stymied for space often. And if you think about it, if there's a bar there, fixed beam, hybrid denture, then we would definitely have to drop the whole of the occlusal table for the upper for Anne here, and her aesthetics would be ruined, or just wouldn't be as good at all. And I see it all the time, when I'm watching really beautiful high-end aesthetic work shown with all on 6. The end aesthetics of the actual smile just doesn't look right because of a lack of interarch space. So stop share. Let's come back to me. And let's have a look at the chat there. Miriam Oppenheimer, there are angled curators. That's very true. There are now, but there weren't when I actually did that case, Miriam. How much vertical space do you need for that bar retained maxillary denture? Ned Flanders has asked another question. So a lot is the answer to that question, Ned. I can't remember off the top of my head. I hardly ever do them. Did you have any problem cleaning in the back of the bar? No, interdentally. So Laura Tassel, how did Olive react to ending up with a full plate of courage? Very cross. Miriam Oppenheimer. Miriam Oppenheimer. Could the break happen because of lack of posterior teeth in the lower back for her? Definitely would be a big factor, sort of doing this. But I think it's really just due to that implant failing as well. Ned Flanders again. How badly were you sweating when Olive came back in with the broken butt and lost implant? So, very worried, of course. Thank you very much, Angela. Some lovely comments here. Great cases. Lovely. Michael Collar, how do we register for next week's webinar? Go to my blog, Michael, on my website, and then have a look at the blogs down there. There'll be the Q&A session on there. Just scroll down. You'll see it for that, or go to my Facebook page, my Finlay Sutton Removable Education Facebook page. That was great. Thank you. All very nice comments. Hi, Finlay. Adam Morris. If you have an ICP with natural dentition for partial, and you want to place a backing as you have on the uppers, would you prep the teeth a little to give the space, or accept a slightly open vertical dimension and try and let it dial in? Thank you. Adam, in general, with a case like that, we would have a completely new, we just open it up on the whole of the denture. So both the back teeth and the backings, we just open the bite up onto it. So it's a bit like a splint, just jacked open a little bit. So Mark Bishop, he said, so glad you've pointed out the perils of implants. They can be great, but they can cause your hair to change from brown to grey. Nothing can beat good basic prosthodontic skills. Yes, I totally agree. That's lovely. Hi, Mark from Israel. It's great. Thank you. I didn't know what your name was in Hebrew. It's lovely for you to join us. So Neil Patel, many thanks, Finlay. Outstanding presentation in great detail. Regarding the last case, failed implant and fractured bar, was there any protection for the bar? Splint, soft, hard against natural lowered teeth when overdenture not in situ at night? And do you think replacement of the missing lower teeth may have reduced the likelihood of the complication? Many thanks, Neil. So yeah, in answer to your questions, yes, I think having posterior teeth over those implants would be better. So we've got less rocking forces. Yeah, so that's a good point. And at night, she wore the dentures at night actually as well, Neil. So she had a splint. So she had the upper at night, a soft splint on the lower as well. I didn't want her to bite on that bar with her natural teeth directly. What does that, Miriam? I don't understand your question again here. Would you have a metal reinforcement before making the implants? So I don't understand your question because flipping heck, I like metal reinforcing everything because with implants they break. So Tahid Hamid, hi Finlay, can I ask, are you happy to have a cantilever on an upper bar in the maxilla? Well, yes, I am, if it was supported properly, but it failed, didn't it? But if you actually look at a lot of John Coyce's work and how he recommends all on sixes should be with a bar sleeve system, they like to have all the implants at the back. I've got one here actually that Ruth Burke showed me. So this is the system that John Coyce really loves. So we've got implants placed in the maxilla here. It's a parallel bar, and then there's a sleeve that actually gets encased in a denture. It's got a Mark II attachment. This is an R.E. Burke bar, Ruth Burke's design, and this all slots in together beautifully and fits. It's just like fantastic. So, and this is using quite a long cantilever, but it's not. The main issue with Olive was that she lost that anterior implant that supported it. And as soon as that was gone, we are goonded, as it were. From Miriam Oppenheimer, with time, the bone resorbs. So how do you make sure the bone in only on the implants without the soft tissue support in not only on the implants? Yeah, that's true that we do get bone support resorption posteriorly behind implants there. But I tend to find that there's no resorption on the buccal plate. This is really important, Miriam. Buccal plate, it stays still. That's basal bone. If the denture is supported really well by that buccal bone and it goes up on the retromolar pad, then I find that relines are just not necessary for lowers. That's just how I feel about it and what I see. That's great. Anthony Varos from Melbourne. Thank you. Kai Yin Yan. Excellent. Thanks, Michael Vida. It's lovely. Hadas Hella, hoping the sky will be open so she can come to courses. You're very welcome. That's great. Minesh, you get that Gothic arch ordered. It's brilliant. Lila, Brett, thank you. That's great from Australia. It's lovely. Superb. Okay. And Miriam, so you talked about making dentures that give you the aesthetics before putting in the implants. Do you reinforce with metal? Do you use them as finals? So yeah, so no, Miriam, first of all, we get the teeth in the right place just using a plastic denture, and then we then engineer it so that the bar is made, or the metalwork will fit within that shape of that denture. So it's later on. So no, I don't use, I like to use my first set of dentures like a diagnostic, so they're plastics, and then that gives us loads of information, loads of stuff for the final ones. Thanks, John, for your answering the question. 15 to 17 millimeters of crown height space for a bar overdenture. So that's brilliant. I was thinking 20 millimeters in my head. So that's brilliant. That's lovely. Excellent. Yeah, you're right, John. Spot on. It is. It depends on your attachment too. That's great. Okay, let's have a look at the time. I'm going to switch off now. I'll upload this lecture onto YouTube as well, so you can see it again later. Thank you very much for spending your time with me today, and I will be doing this again later on today, and hopefully we'll see you next week. So thank you very much indeed, and great questions. Bye for now. Bye-bye.